On subclinical thyroid diseases or thyroid vigilance. I welcome the chairpersons, Dr. S. Sridhar, Associate Professor, Department of Endocrinology and Metabolism, Madurai Medical College. He was the treasurer of ASTN from 2015 to 2018. Having multiple publications, he was awarded as the best outgoing student in MD at JIPMER 2008 and ESI TISA and AV Gandhi Award winner of 2012. I welcome Dr. Shivan Arul Selvan, consultant endocrinologist, Pondra Hospitals, Tirunelveli. He had presented multiple papers in national conferences and has been a co-investigator in multiple clinical trials. I request the chairpersons to introduce the speakers and take over the session.
Thank you, Dr. Vijay Bhaskar and organizing team. A warm welcome to all respected doctors, teachers, and colleagues. We have two interesting thyroid topics. The first talk will be on subclinical thyroid disease. And to discuss this, we have Dr. Petros Peros, who is a senior consultant endocrinologist from UK. He is working in Royal Victoria Infirmary and Newcastle University. He has multiple original works in thyroid disorders, specifically in Graves' thyroid orbitopathy. And he has been a past secretary and president of
Dr. Sivan, you are muted actually. Please unmute and.
Okay. Okay. Am I audible now?
Yeah, you are audible.
Okay. Respected doctors, colleagues, and teachers, we have two topics in this thyroid session. First is the subclinical thyroid disease, which will be discussed by Dr. Petros Peros. He is a consultant endocrinologist in UK Royal Victoria Infirmary and Newcastle University. He has multiple original works in thyroid disorders, specifically in Graves' thyroid orbitopathy. He has been the past president and secretary of European Group of Thyroid Orbitopathy, which has published a management of Graves' orbitopathy guidelines. He is currently leading a global collaboration between European and American Thyroid Association regarding novel treatments in Graves' orbitopathy. He has more than 168 publications, which is peer-reviewed. So a warm welcome to Dr. Petros Peros. Over to you, Dr. Petros.
Thank you very much. Can you hear me okay?
Yes, sir. You can go ahead.
Okay, so...
you can share your slides.
Okay.
Yes, sir. Slides are visible.
Can you see my slides?
Yes, sir. Yes, sir. Can
yes.
Go ahead.
So hello, and thank you so much for the invitation. It is such a shame that I can't be Chennai. I'm stuck here in Newcastle and looking outside my window. It's a grim December's day. And I'd like to thank very much the organizing committee and particularly Dr. Reddy for the invitation and Mutu for inviting me. Mutu and I go back a long way. He was with us up here in the northeast of England some time ago. And also, I'd very much like to acknowledge these two extraordinary individuals because they have helped me and millions of people cope with the drudgery of the pandemic over the last year by providing us with daily light entertainment. And I will miss Donald Trump very much when he goes. Now, if we were to turn the time back to the time many years ago when I started in endocrinology, it was a different world. And most of the patients, if you were to attend the waiting room of an outpatient clinic, looked like textbook cases. You know, you could spot the diagnosis from the distance, and that's how it was. Things certainly have changed in the UK, and I expect the same in India. And most of my patients in my waiting area, when I go to do my clinics, look pretty ordinary and as normal as anybody else. So in the spectrum of abnormal and normal, we have a gray area right in the middle, which is subclinical disease. It's characterized by abnormal tests, and the clinical features are absent, or indeed they may be totally misleading. So over the next 20 minutes, what I will do is share with you some of the nuances of these two conditions, subclinical hyper and hypothyroidism, by sharing with you some cases from our own clinic. And I would add that I'm not going to talk about pregnancy, and I'm not going to include children or patients who are already on levothyroxine treatment. So starting with subclinical hypothyroidism, the definition is biochemical. So a low TSH with a normal 3T3 and 3T4. It's a common condition in some parts of the world where there is iodine deficiency. It can be as high as 16%. And my first case is an elderly lady, Agnes, aged 82, and she had routine blood tests. I don't know exactly why, but nonetheless, they showed a suppressed TSH and normal 3T4, and the GP's referral was very laconic, see and advise. And so she attended with her daughter, and in fact, the daughter did most of the talking and started off immediately by telling me that she's done her research about subclinical hypothyroidism. So this is Dr. Google. And she said, I'm so pleased that the cause of mummy's forgetfulness has at last been found, and you will put it right, doctor, won't you? And then she added, by the way, I'm a lawyer specializing in medical negligence. And so the assessment of this patient, the history was that she was getting a bit forgetful. She lived in a home, had some comorbidities, and examination was entirely normal, except that she had a small nodular goiter. And so one of the questions that arises in this situation, I put that to some of my trainees recently, is should you do any additional tests to try and get a better picture? And this is the list that comes up, and let me just go through this. Doing a free T3 level is really important, because I'll remind you that T3 is the biologically active hormone, and if that is elevated, I don't care what the free T4 is, that becomes overt hypothyroidism that needs treatment. In her case, the free T3 was normal. Looking for previous thyroid function tests is also useful and part of the investigations, if you like, because in a proportion of patients, this aberration thyroid function test is transient and corrects itself spontaneously. You could do more tests. You could do autoantibodies, an isotope scan, and so on. But I would argue that these are only necessary once you have made the decision to treat the patient. They can guide you as to what might be the most appropriate treatment. And then you can do a DEXA scan or an ECG. They may be helpful in deciding whether to treat or not, but in my experience, when the history and examination are, as in this patient, they're hardly ever useful. And then finally, there's the 5MX test, which is absolutely essential, and I shall come back to this a little later. So just to summarize, this is somebody with cognitive impairment who's 82 and subclinical hypothyroidism, and has a daughter with very high expectations. And the question is, do you treat or not? Or another way of looking at this is to ask, what are the health consequences of this condition? And dementia, of course, is in the top of the agenda for the patient's daughter. And if we look at that, the state of the art is summarized in this comment from a meta-analysis. So there is ample evidence showing an association between subclinical hypothyroidism and dementia, but the available data are limited, and we need more studies to actually try and understand this better. You can look at other parameters, the overall mortality, cardiovascular mortality, atrial fibrillation. And here is a meta-analysis which again confirms there is an increased risk of mortality. And most of that is cardiovascular. There is an increased risk of atrial fibrillation. If we look at osteoporosis and fractures, again, a very large meta-analysis that shows that there is indeed an increased risk of any fracture, and indeed hip fracture, associated with subclinical hypothyroidism. But then you need to take this a little further and ask the question, what are the gains if you treat it? And if you look at these four major outcomes, the answer is that there is no evidence available that treatment makes no difference. And that's not through lack of trying. So over the past 15 years, there have been at least 4 studies trying to address this question, including one from our own center. And none of these have been published. Most of them have been abandoned because you need a very high number of recruits for a very long period of follow-up to actually answer this question. So this is a common scenario, I think, in clinical medicine that we encounter frequently. You have an association. Is it causative, and does treatment prevent the outcomes? And in the case of subclinical hypothyroidism, there are some uncertainties about these. What is not controversial, I would say, is that if this is due to exogenous thyroid hormone, then it is worthwhile correcting it. And the evidence, although circumstantial, I think is quite strong that if there is new onset atrial fibrillation, it is worthwhile treating, because that will increase the probability of restoration of sinus rhythm and maintenance of sinus rhythm. What about guidelines? Well, the European Thyroid Association recommends that for patients over the age of 65, and especially when the TSH is completely suppressed, you should treat. The American Thyroid Associations are similar, but even more aggressive. I would suggest that younger patients with risk factors should also be considered for treatment. Let's take this a little further. If you treat, what treatment do you use? And the answer is the same as for any other kind of hypothyroidism. I put thyroidectomy in brackets because I think that's very heavy-handed, unless there is a huge goiter which is causing compression, or if there is concern about an underlying cancer. So the benefits of treatment are theoretical. What about the downsides? There are always downsides, and these are outlined here for antithyroid drugs and radioactive iodine. So a significant minority of patients treated with these modalities will have significant side effects. So how do we decide to treat or not to treat? I think the essential elements are, we need to be aware of what the evidence says, and having good quality information is important. And you need to be aware of all the options that are available. We need to be guided by the principles of doing no harm, and to respect the patient's views and patient's autonomy. But I strongly believe that physicians should not sit on the fence. It's not a question of just simply telling patients all these and telling them go away and make a decision. Our role is actually to come down and decide one way or another. And this is where 5MX comes into it. 5MX stands for 5 minutes of extra history. And if you apply that principle, as in this case, then some interesting additional information comes into the surface, which actually can make a difference. So this patient, it turns out, has incontinence. She has frequent urine infections. She detests going to the doctors and having blood tests, doesn't like taking tablets, likes to be with her grandchildren, and anything that comes in the way upsets her, and generally gets upset when the routine is disturbed. So with that in mind, a discussion followed with her and the daughter, in which I explained the diagnosis, treatment options, potential side effects, and I told her that I recommended no treatment in her case. And interestingly, at the very end, I asked if she had any questions, and Agnes said, "I've had a good life, I don't want any more tablets or blood tests." So I think she made an informed decision, even though she had some cognitive impairments, that this was the right approach for her. And more importantly, the litigation lawyer agreed with this outcome. So my conclusions about subclinical hypothyroidism are, there are associations with poor outcomes. I think any treatment effect is likely to be small, judging by the difficulties that the various studies have had in providing answers. And as always, we need to consider the balance between benefits and side effects for each individual patient. If I may now turn to subclinical hypothyroidism, again, the definition is biochemical, and most people understand by subclinical hypothyroidism, a TSH which is raised, but less than 10 with a normal 3T4. Fairly common in some countries, up to 12% of the population may have subclinical hypothyroidism. And this is my second case. This is a younger patient, aged 45, who presents with a 2-year history dominated by excessive tiredness, but a variety of additional symptoms. In fact, she presented me with a list, a very long list that she compiled. And she, interestingly, a year before she presented to me, she had a normal TSH. So this is after the onset of her symptoms. Now the TSH was 6.2, and clinical examination was entirely normal. So what do you do next? Well, you can do all of these things. Checking the TPO antibodies, I think, is useful because it gives you some idea of what the risk is of progression to overt hypothyroidism. It is worthwhile waiting and repeating the thyroid function test because in a significant proportion, this is a transient event. It will normalize. And it is also important to think of other causes of these non-specific symptoms, and there are numerous of them, as you well know. So 3 months later, her serum TSH is still elevated, TPO antibodies are positive, and she is desperate to start treatment for hypothyroidism. And so the question is, what do you treat or not? Or we can rephrase this question, what is the probability of her excessive tiredness and all the other symptoms getting better with treatment? And there are good studies. There are at least 6 randomized controlled trials comparing placebo versus levothyroxine in more than 1,000 patients altogether. And this is the outcome. In 4 out of 6, there is no change in quality of life or symptoms. In 1, there is improvement, and the other, there is deterioration of symptoms. And so my interpretation of this is that, and my clinical experience, in fact, is it is unlikely that patients will derive symptomatic, long-lasting improvement from treatment. Nonetheless, 3 months later, she has been put on levothyroxine, and she comes back saying she's feeling a little better. Now, if you've been around for as long as I have, you turned a little bit cynical, and the cynic in me will say, maybe this is just a placebo effect. TSH is now in the normal range, and she's aware of that, and she's done her own research, and she's asked the question, should I increase the dose? So the TSH is in the normal range, but the upper end. And is there any benefit in fine-tuning the thyroxine? And there's one really important study that I'd like to share with you from Mary Samuels from the west coast of the US, a really nice randomized controlled trial of patients on levothyroxine whose dose was changed to achieve different target TSH levels. And they stayed at that level for several months and then assessed at the end of it. And the range of TSH achieved was between, at lower end of the normal range, right up to 9.5. And to cut the long story short, there was no difference in terms of quality of life, mood, and cognition, whether your TSH was 1.85 or 9.45 in this particular prospective randomized controlled trial. 6 months later, she's still on the same dose. Her serum TSH now has drifted to the upper end of the normal range, and she's feeling back to square one. And so again, the cynic in me tells me the placebo effect has worn off. And at this point, she broke down in tears in my clinic, and rather belatedly, I applied the 5mx test. And a bit of extra history revealed that the marriage had broken down 2 years earlier. She had financial concerns, her children were still unsettled, and she asked the question, do I really need to keep on taking these pills because I forget and it stresses me out? So the question now is, forget symptoms, is it worth continuing to treat in somebody like this? In other words, are there other potential gains besides symptoms. So again, there are well-established associations with hypolipidemia, cardiovascular events, heart failure, and mortality. But there is no evidence of benefit from the 6 randomized controlled trials that I showed. Now, to be fair, these probably have not gone on long enough to actually be able to give a definitive answer to this question. So there is a question mark as to whether these patients benefit for sure or not. But certainly in the short term, they do not. So at this point, I discussed the pros and cons of continuing treatment, and I advised her to stop and have annual TSH by her GP, guarding against overt hypothyroidism. And she thanked me and told me that she was feeling much better now, that she did not have to think about taking tablets that made no difference to her. So last year, the National Institute of Health and Clinical Excellence in the UK produced some recommendations about this. And what they say is we should use the targeted approach. So if symptoms are symptomatic, and if the background suggests that they are at high risk of developing overt hypothyroidism in the near future, so if the TSH is more than 10 after a thyroidectomy or post-radioactive iodine, then it's reasonable to give them a trial of treatment of 6 months and then reassess. And the factors that may swing us in favor of treatment rather than not may be things like having a goiter, planning surgery, young age, hypolipidemia, high risk of cardiovascular disease, and patient preference. Now, I'd like to just say a couple of things about some lessons that we've learned in the UK that relate to patient expectations and subclinical hypothyroidism. And if we look at the prescriptions issued for levothyroxine, in the last 20 years, they've trebled. And what is interesting is if you look at the threshold TSH at which GPs in the UK start patients on levothyroxine, it's shown here. So the horizontal axis is the TSH level, the vertical is the number of patients. And the first thing to say is that in 10% of cases, GPs start levothyroxine treatment in euthyroid patients, completely normal TSH. And in another 51% of cases, the TSH is elevated but below 10. So the majority of newly diagnosed patients with hypothyroidism in the UK either have normal or slightly elevated TSH. Last year, we did a survey of patients with subclinical hypothyroidism with in collaboration with the British Thyroid Foundation, and this was very interesting. And it turns out that 90% of patients with subclinical hypothyroidism expect all the symptoms to disappear with treatment. Contrast that with the randomized controlled trials that showed no significant change in symptoms. And a significant minority, 10%, expect the symptoms to disappear immediately, and that is within days of starting treatment. So, at least in the UK, and I think in actually many other countries, there is overdiagnosis, there is overtreatment, and there is failure of managing unrealistic patient expectations, which drive patients to seek alternative treatments that could be harmful and damages their patient-doctor relationship. So, my take-home message, ladies and gentlemen, about subclinical thyroid disease is don't do thyroid function tests unless there is a good clinical indication. If you find subtle minor abnormalities, don't rush into treatment, but wait and repeat. Remember the importance of 5 minutes of extra history and the importance of managing patient expectations. Thank you very much.
Thank you, Dr. Petros, for the excellent discussion on subclinical toxicosis and subclinical hypothyroidism. We have another 5 minutes left for discussion, so we'll take up questions now. I will start with the first question. Last year, there was a publication in BMJ which came to a sweeping conclusion that treating majority of subclinical hypothyroidism is not useful when the TSH is up to 20, except in children and pregnancy patient. What is your take on that publication?
Well, I'm in general in agreement with it. One area that I would deviate from that particular suggestion is they went up to 20 milligrams per liter as being the cutoff. Now, the data about symptoms and outcomes for patients with a TSH between 10 and 20 is very limited. So that's a generalization from a very small proportion of patients. And so I would disagree in that respect. I think when the TSH is above 10, the evidence is in favor of treating rather than not. The chances of improving symptoms increases, and the chances of improving the outcomes, some of the other sort of cardiovascular and other adverse events, it goes up very steeply. So strictly speaking, yes, that's the statistical interpretation that up to 20, there's no definite benefit, but that is based on a very small number of data.
Thank you, sir. Regarding this thyroid antibodies, generally we do only TPU antibody as a cost-saving measure. Should we do both TPU antibody and thyroglobulin antibody before concluding that patient is antibody negative, or only TPU antibody is sufficient?
Yeah. So of patients who have autoimmune thyroid disease, the vast majority will have 90+% will have positive TPU antibodies. Those who have negative TPU antibodies but have positive thyroglobulin antibodies is a small minority. So you can increase that kind of level of certainty, if you like. But nonetheless, the risk of developing overt hypothyroidism in future is based on TPO antibody positivity rather than thyroglobulin. I think you can increase the level of certainty that somebody has autoimmune thyroid disease if you include thyroglobulin. I don't routinely do that. I think going by TPO is sufficient.
And regarding TPU antibody positivity, is there a correlation between the amount of TPU antibody elevation and the natural progression of hypothyroidism? Suppose TPU antibody is only mildly elevated and severely elevated. Is there any correlation in natural progression?
So the risk of patients who are positive, so patients who have subclinical hypothyroidism and have positive TPO antibodies, the risk is roughly 5% per annum. Now those calculations, those estimations are based on the dichotomous nature of positive and negative antibodies. So that's what the big data are based on. There are less robust data that suggest that the higher the TPO antibodies, the quicker the transition will be into overt hypothyroidism.
Okay. There is one question in the chat box. What is the safe TSH value for subjecting asymptomatic patient for elective surgery?
That's interesting, thank you.
Yes.
And very relevant. Actually, not so long ago, a relative of mine was refused major surgery for cancer because he had some TSH was mildly elevated, and I had to intervene and reassure them that it's okay to go ahead. So there are good data that subclinical hypothyroidism is not a problem going through surgery. There are reasonable data that hypothyroidism itself, as long as the patient is not severely affected and is not grossly hypothyroid, that most of the outcomes of surgery are actually fine. So the way that I would approach this, if there is elective surgery planned, then obviously the right thing to do is to correct the serum TSH. If you're faced with somebody that needs life-saving surgery and has a TSH of 10 and otherwise is clinically okay, I would have no hesitation in saying that person is fine to go through surgery.
Coming to the last question, are there any diet modifications for subclinical hypothyroidism? Any diet changes is to be recommended?
That's a very interesting question, and if you happen to go on patient blogs, and there's lots of them in the UK and the US, and I bet in in India, you will see a lot of material about exclusion diets, particularly gluten-free diets and all sorts of things. And there is a lot of scientific interest in this because the diets affect the microbiome, and there's a lot of interest and some preliminary evidence that the microbiome in autoimmune thyroid diseases may determine the robustness of the autoimmune response. But in terms of robust data, or whether the diet makes a significant difference, they're lacking. There are good data that selenium supplementation reduces the level of TPO antibodies, but that doesn't translate to preventing hypothyroidism or reversing subclinical hypothyroidism into normality, although there are some ongoing studies that will specifically address that.
Okay, sir. Thank you. With this, we'll end this session. Thank you, Dr. Petros, for that excellent discussion. We'll go to the next topic, and Dr. Sridhar will welcome this speaker. Over to Dr. Sridhar.
Good evening, one and all. Thank you, Dr. Sivan. And so the next topic on thyroid vigilance. Basically, it is a less often discussed topic to create awareness among the physicians regarding the thyroid screening, as well as the treatment, as well as the preventive aspect of thyroid symptoms. For the topic, on behalf of ESTN, I have the privilege to invite Professor Dr. Sanjay Kalra sir. Sir is a well-known, renowned endocrinologist all over the India, and he is alumni of AIMS New Delhi with more than 30 years, 25 years of experience in endocrinology. And currently, sir is a visiting professor in AIMS Rishikesh and immediate past president of Endocrine Society of India, as well as the vice presidents of South Asian Federation of Endocrine Society, as well as one of the dynamic leader with a great visionary to recognize the endocrinologists across the globe. And one of the significant achievement is Sir was an editor-in-chief during the IJEM, Indian Journal of Endocrinology and Metabolism, the journal being widely recognized and highly impacted among the Indian journals, as well as the highly indexed journals among the other Indian journals. So with the kind introductions, I would like to invite Professor Dr. Kalra sir for given the topic on thyroid vigilance. Over to you, sir. Thank you.
Thank you, Dr. Sridhar, for those kind words. And I'd like to thank the entire Trendo team, including Dr. Vijay Bhaskar Reddy, for inviting me here. Like Dr. Sridhar said, I just stepped down from the presidency of the ESI. But what Dr. Sridhar forgot to tell you was that the beginning of my presidency, that was thanks to the Trendo team, and that was in Madurai. Dr. Kumaravel and Dr. Sridhar conducted the first satellite symposium of Endocrine Society of India there, and that has set the tone for academic discourse across India in endocrinology. We have become a more endocrine vigilant nation now. And I'd like to thank Dr. Petros for his talk. His very simple, very structured talk, in which he made it very clear for us how we should be careful about screening, about diagnosing, about managing subclinical hypothyroidism. Dr. Petros, I'm reminded of one of my favorite stories when I was a child, and that is Goldilocks and the Three Bears. So when Goldilocks went into the bear's house, there were some things that were too small or too little, others were too big, and then there was just something that was exactly right. And I think that is what you tried to point out for us. TSH, when you look at TSH normal range, it may vary, for example, between 0.5 and 5.0. But for each individual, there is a Goldilocks range where you have to try and keep the TSH in. And just like every Goldilocks of the world has a right to her own choices, similarly, every individual in the world, every man, every woman, every boy and girl has a different Goldilocks range for his or her TSH, for his or her thyroid function. With this in mind, let's talk today about thyrovigilance. And we'll try to make things simple for ourselves. We'll try to make things simple for our patients and our colleagues as well, so that we can spread the word, the good word about good thyroid health. This is important because as a country, we face a very thyroid disorders. Hypothyroidism, some studies say more than 1 in 10 adult has subclinical or overt hypothyroidism. Autoimmunity, Dr. Petros just spoke about anti-TPO and anti-TG. Some of our studies say that nearly 1/6 of all adults in India, all adult women in India have positive antibodies. The percentage of anti-TG antibodies is slightly higher in North India at least. And maybe from a Haryana perspective, I would say that around 25% of our patients have positive anti-TG antibodies, even though they have negative anti-TPO. But then there will be a lot of regional variation within India. And there will be so much of regional variation that we would request each physician, each endocrinologist to find the right proportion and to decide the right method of screening or vigilance for his or her own area based upon local data. Congenital hypothyroidism is quite frequent as well. And one of the leaders in India is the state of Kerala, where there is mandatory.
Sorry to interrupt, sir. That voice is a little bit breaking, sir.
Okay. Is it better now?
Yes, sir. Yes, sir. Yes.
The leader for congenital hypothyroidism screening is the state of Kerala. And there the rate has been found in some studies to be nearly 1 in 1100. Thyroid cancer is also being diagnosed more and more frequently in India, more in some states than in others. And what this all means is that we have to be vigilant. If we are vigilant, we will be healthy. And one of the areas in which we can become most vigilant, or we can become vigilant most easily with the maximum possible benefits, this is thyroidology. So it's very low-hanging fruit for us, for the physician, for the policymaker, for the person who is in charge of the healthcare system. Let's discuss vigilance in different ways, but what comes most easily to us is clinical vigilance. And as physicians, of course, we look at laboratory reports, we look at lab abnormalities, but we should not lose sight of symptoms and signs, which are the bedrock of clinical vigilance. The only challenge, however, is that when you look at the symptoms and the signs of hyperthyroidism or of hypothyroidism, this reads like the entire Harrison's textbook of medicine. The point being made here is that if a person comes to you with any kind of a symptom or a sign related to any organ system, do think thyroid, at least for a second. When I was a student, and I remember in psychiatry being taught that if there is a person who presents with symptoms or signs related to 3 or more than 3 organ systems, for example, the cardiovascular system, the nervous system, and maybe the musculoskeletal system, then you think psychiatry. But now I realize that actually it's exactly the obverse which is true. If a patient comes to you with 3 or more than 3 organ systems being affected, you have to think endocrinology actually, because it is the hormones of the body, including insulin, including the thyroid hormones, which actually circulate throughout the body and which take care of each and every organ system in the way that is required. Dr. Petros spoke about the indications for management of subclinical hypothyroidism. And perhaps towards the end of this talk, we can ask Sir to comment upon 2 specific things. One is depression, and the other one is chronic kidney disease. People with depression, people with chronic kidney disease do have a high prevalence of subclinical hypothyroidism. We know that these are not strong indications for treating with thyroxine, but they certainly are soft indications. So this would perhaps we'd like Dr. Petros to share his personal experience from his clinic. What happens if you treat CKD or depression with thyroxine? In fact, even for euthyroid depression, some authors do suggest that thyroxine can be used in small doses. We've spoken of clinical vigilance. Within this concept of clinical vigilance, let's focus on 2 aspects. One is medical and the other one is metabolic. Now, medical vigilance means that if you are in a medicine clinic, for which clinical situations will you go out of the way to suggest a thyroid test? In pediatrics, that would be short stature or pubertal disorders. Anybody with a swelling in the neck or a goiter. women coming in with menstrual irregularity or galactorrhea, patients who are using amiodarone, lithium, drugs for weight loss, who are using bodybuilding drugs, they're going to the gym and they're getting a cocktail of hormones, people who've been exposed to irradiation or surgery of the neck. All these are patients who deserve thyroid screening. Also, those with a family history of thyroid disease, and those who live in areas which are iodine deficient and which are not covered with iodized salt. All these are patients who deserve thyroid screening. At the same time, if you happen to have done imaging and you happen to have found ovarian cysts, polycystic appearing ovaries, or perhaps a pituitary mass, or pericardial effusion or pleural effusion, then again, thyroid vigilance is indicated. If you're treating somebody with an autoimmune disease, think autoimmunity, think polyglandular autoimmunity, and get a TSH done. If you have a patient with cardiac disease, like atrial fibrillation, or a musculoskeletal disease, like hypokalemic periodic paralysis, or osteoporosis, then again we screen for hyperthyroidism. Amiodarone and lithium, these are two drugs that can cause thyroid dysfunction. And if you have patients on these drugs, we need to keep on screening for thyroid dysfunction. Do remember that even after amiodarone has stopped or after lithium treatment has stopped, even after that, you can have abrupt onset of thyroid disease. So the screening has to go on for even up to a year after lithium or amiodarone have been stopped. We spoke of metabolic vigilance, medical vigilance just now, but let's look at metabolic vigilance, and let's talk of a concept known as thyroid dysmetabolism. Now, when we are treating a person with thyroid disease, our aim is not just to give a normal TSH. Our aim is to give good quality of life as well. And even within the biomedical sphere, even within the sphere of numbers and laboratory values, our responsibility is not limited just to ensuring that the patient has a normal TSH. When Goldilocks went to the house of the three bears, she didn't focus on just one thing, maybe upon the bed or the pillow or the dining chair. She looked at the house in its entirety as a holistic as a holistic thing. So similarly, if you're treating a person with thyroid disorder, you have to focus on glucometabolism. That means you have to know that there will be some people who are prone to diabetes, like for example, hypothyroid patients may have a high risk of type 1 diabetes. Because of insulin resistance, type 2 diabetes may also be increased. At the same time, a person who is not treated, a person who is hypothyroid or who has pan-hypopituitarism may be prone to hypoglycemia. So you have a person who is doing very well on whatever glucose-lowering therapy he or she is getting, and suddenly hypoglycemia begins to set in. It may be renal impairment, it may be hepatic impairment, but it also may be hypothyroidism. So we have to focus on glucometabolic optimization as well. Another aspect of metabolic vigilance is barometabolism, where we look at weight. Now, one of the most common reasons for a person with hypothyroidism, real or imagined, to come to an Indian clinic, whether to Dr. Vijay Bhaskar Reddy or to Dr. Sridhar or to myself, that is overweight or obesity. So we have to optimize that. We have to know how to counsel the patient and how not to. Along with barometabolism, we have a sister metabolic dysfunction, which we call lipometabolism. So we have to understand the relationship between dyslipidemia and thyroid disorders, and what to treat and how to treat, in which order to treat. We've spoken of metabolic vigilance, medical vigilance, but between metabolic vigilance, we should not forget the other organs of the body. I began by speaking that earlier, if you had 3 organ systems being involved, or more than 3, think psychiatry. But like I said, that's wrong. You have to think endocrinology. And this slide in front of us shows us exactly why. If you have a person with NAFLD or MAFLD, the new term now is metabolic associated fatty liver disease, a person with polycystic appearing ovaries, and a person perhaps with osteoporosis, what will you think of? You will think of metabolic dysfunction or hormonal dysfunction, and hypothyroidism fits the bill here. Now, we've talked of all our responsibilities as a physician, as a clinician. We have to think of the symptoms and signs. We have to think thyroid when we are treating medical and pediatric patients. We have to think thyroid when we are treating metabolic patients. And we have to be metabolically vigilant when we are treating thyroid patients. But apart from the clinical part, we have to look at the laboratory as well. Because you remember the definition of a syndrome? A syndrome is defined as a constellation of abnormal symptoms, signs, and lab values. So the lab vigilance is very important. We have to understand which assay we are using, how effective it is, how sensitive it is, and how specific it is. We've talked of symptoms, signs, and lab abnormalities now, but let's focus on a few specific aspects of vigilance. One is during pregnancy, before pregnancy, and after pregnancy. So our chairperson, Dr. Sridhar, is in Dr. Petras. Dr. Sridhar is an expert in this particular field of thyroidology about creating India-specific, trimester-specific reference ranges for TSH. So, like we said, we are a big country, but there are many colleges, many academic departments in the country which have their own specific ranges. We've not been able to create all India references. That I think is a bit too big. That would be like saying create Pan-Africa ranges, normal ranges. So that would be a bit tough. But overall, we do encourage universal screening for thyroid dysfunction in pregnancy in India at the first antenatal visit. If a woman is found to have overt or subclinical hypothyroidism, then we keep on screening regularly. And you treat as per recommendations. Women who are presenting with subfertility or with bad obstetric history, these also must be screened for thyroid dysfunction, including autoimmunity. Once pregnancy is over, we also have to be vigilant with the newborn, and we've mentioned the reason why. Let me use a term here called transgenerational karma. So Dr. Petras, karma in the Sanskrit language can be taken to mean past tense, what you did earlier, what you're doing right now, and what you will experience in future. So it's past, present, and future tense. The term transgenerational karma means that if before, during, and after pregnancy, the lady follows the right karma, she will be able to transfer this merit to her unborn child, and the child will continue to experience or reap the benefits of that karma even into adulthood. The 5 numbers that we propose for every woman to take care of pre-conception and during pregnancy are hemoglobin, blood pressure, weight gain, glucose, and TSH. So that is why TSH is important. If all these 5 numbers are taken care of, we can, with great confidence, we can promise the lady that not only will your own health karma be good, but your child's karma will also be good. Continuing with that, we have to explain to some of our colleagues sometimes that congenital hypothyroidism is different from autoimmune hypothyroidism. In pregnancy, we are more often than not, we are treating autoimmune thyroid disorder. But in a neonate, when we screen for hypothyroidism, we are not screening for autoimmunity. We are actually screening for congenital hypothyroidism. This may sound simple to our chairpersons and to our speakers, but when we are speaking to practitioners across the country, we have to explain this to them, because there are many centers in the country still which will do selective screening for congenital hypothyroidism. If the mother has been on thyroactive therapy, the child will get screened. If the mother has not been on therapy, the neonate will not be screened. Pediatricians are in general aware of the clinical features of hypothyroidism, but the point is that we should screen as early as possible within the first 24 hours. If there is a doubt, there is no harm in initiating with the thyroxine, but just keep on monitoring the child at regular intervals. Also, remember that the per kg dose of thyroxine reduces with age. So the per kg dose requirement of thyroxine will be the highest in the neonatal period, and it just keeps on going down until the geriatric age group. We've spoken of medical metabolic vigilance. We talked of specific age groups or phases of life, the antenatal period, the neonatal period, and now this is COVID time. So we have to be vigilant, thyrovigilant in critical care as well. Sick euthyroid syndrome is something that we all must be aware of. If you have a patient with low T3, the patient may be having a critical illness which is causing the low T3. So in the ICU, if you find a low T3 suddenly, think sick euthyroid syndrome. If this worsens, it will become low T3 and low T4 as well. And if the critical illness becomes more severe, then it becomes low T3, low T4, and low TSH. There are multiple reasons for this. There are differentials as well, because if you have a low T3, low T4, low TSH, you may be having central hypothyroidism, which has to be treated at all costs. But the clinical situation will actually help the physician, the intensivist, understand whether to treat with thyroxine or not. It is important to know about this because these are COVID times. COVID is associated with thyroid dysfunction in so many ways. And again, it would be nice if Dr. Petros could speak to us about the experience in Europe and in America. Is the prevalence of subacute thyroiditis going up after COVID, which many of us in India are seeing? We are seeing a spurt in the cases of subacute thyroiditis. It is important to know all this because you have to achieve the right diagnosis so that you can treat properly. Because if we overtreat, that can also lead to side effects. Iatrogenic hyperthyroidism and iatrogenic osteoporosis is not something that we would want to cause in our patient. And certainly we would not want our patient to land up in thyrotoxic crisis or with unstable angina. Neither would we want atrial fibrillation to occur because of our therapy. So therefore, we have to be pharmacologically vigilant as well. I used the word pharmacological vigilance for the previous concept. Now I use the word medication vigilance, because when we diagnose and when we treat thyroid disease, our job is not over. We have to counsel the patient as to how to take thyroxine properly. So it may be a tiny tablet weighing just 50 micrograms or 100 micrograms, but it is important to know how to take the tablet. And this checklist from the Indian Journal of Endocrinology Metabolism is actually a very comprehensive checklist for how to counsel your patients to take the tablet. And also, if you have a patient with refractory hypothyroidism, or rather pseudo-refractory hypothyroidism, it reminds us to go through this checklist very carefully to make sure that the patient is taking the tablet properly. Also, to make sure that medications like antacids, calcium, iron, and proton pump inhibitors are not taken along with thyroxine, because otherwise these may impair the absorption of the drug. We should also be aware of contraindications and drug reactions, though these are very rare, as long as we treat properly. So to summarize, my topic for today was thyroid vigilance. We have tried to structure this concept of vigilance in different headings. We've talked of the need to be clinically vigilant, to keep an eye on symptoms and signs. The moment more than one organ system is involved, think endocrinology, think thyroid. Be extra careful when you're dealing with medical and with metabolic patients. Be extremely vigilant when you're dealing with antenatal women, women in preconception, and the newborn. Remember the concept of transgenerational karma. And also be vigilant from a point of view of the laboratory, of medication, and of pharmacology in general. So thank you, Dr. Sridhar, for this opportunity, and we look forward to questions. But Dr. Sridhar, you must appreciate, in our talk, we began by discussing the difficult parts, and we already requested Dr. Petros to speak on them.
Thank you very much, sir, for your lucid talk regarding the thyroid vigilance across the different lifespan. And so the questions already you asked to Dr. Petros regarding the increasing prevalence of thyroid disorders, hypothyroidism is in CKD as well as in depressions, as well as the subacute thyroiditis in the COVID. So I think we would all like to hear from Dr. Petros regarding your experience.
Yeah, so thank you. Just to start with the COVID, at the beginning of the epidemic, we were getting a lot of questions from patients about this, patients with autoimmune thyroid disease more susceptible and so on. And at the time, there was some not very good evidence, but there was some evidence that point in the direction that patients with autoimmune thyroid disease or treated hypothyroidism or treated hyperthyroidism were not, in fact, at increased risk of bad outcomes. Very recently, there was some data that came out about outcomes from New York in a population of about 3,000 patients, of whom a minority had hypothyroidism. That's reassuring. It hasn't shown any increased adverse outcomes from having COVID or being more susceptible to having COVID. We will see more data in the next few months coming from Europe, from the UK and Denmark, and I expect they will show a similar thing. If you are inadequately treated, either for hyper and hypothyroidism, whether that poses an additional risk, I don't know, and that's an important and interesting question. So the advice that we give to our patients is that unless you have other comorbidities, you're not more at risk, and just make sure that you take your medication and you keep sort of on top of remaining your thyroid. So that's my answer about COVID. The depression is interesting, and the first thing to say actually about depression is tiredness amongst the symptoms that Dr. Carla alluded to, and I did as well, is a far common manifestation of depression than of thyroid disorder. So nearly 20% of patients who present with tiredness have depression as the underlying diagnosis. And of course, it can be part and parcel of hypothyroidism, and it gets better with treatment, that is in overt hypothyroidism. The data about subclinical hypothyroidism and depression are not impressive at all. And you're quite right, Dr. Carla, there is a habit for some psychiatrists to add T3 to their treatment for refractory depression. They usually add it in large doses, not small doses. They're supraphysiological doses, and they claim some responses. If you look at the data, they're not very robust. I don't have any doubt that in some patients it has an effect. And I think in euthyroid patients, large doses of T3 in particular can have a euphoric effect. That has been kind of recognized. But it's a question of, really wanting robust data if you're going to commit patients to a treatment which is quite heavy-handed with potential side effects. And so my view is that the evidence for overall benefit of adding T3 to treatment of depression is very poor, and I wouldn't kind of advise it or recommend it. I'm sorry, I don't want to hijack the rest of the discussion. Do you want me to carry on, or should we take some other questions?
Kidney disease, sir. I think that would be an important thing for our audience. Chronic kidney disease and subclinical hypothyroidism. Yeah.
So with regards to overt hypothyroidism, no question about it. It raises the creatinine, it impairs CGFR, and I've seen patients being investigated for renal failure when the diagnosis was actually hypothyroidism. With treatment, it completely reverses. I have not seen any data in my own experience of the effect of subclinical hypothyroidism on renal function is not impressive. I don't think it has the same connotations of predicting kind of subsequent deterioration. So in that context, I don't have any serious concerns about the effects of subclinical hypothyroidism on renal function. But if you have a different experience, I'm very keen to hear it.
So regarding the last question that from my end is regarding thyroid vigilance as well as the iodine, whether which iodine to recommend, iodized versus non-iodized, because it is maybe difficult to get the non-iodized salt for the are delicate. What are the carry home message to them, sir?
India is supposed to have universal iodization of salt. If you happen to live in a metro, and if you happen to buy salt from recognized groceries, then you will get only iodized salt. But in many parts of the country, non-iodized salt is used and it is promoted by the alternative therapy people. There is no reason to promote the use of non-iodized salt in India. The only indication you might find would be maybe somebody with uncontrolled Graves' disease, somebody who's not getting controlled on 60 milligram of carbimazole and the adjuvant therapy, and then you think, okay, let me stop iodized salt. Otherwise, there's no indication. On the other hand, being exposed to iodine deficiency can have many side effects, some of which you may not even realize earlier. For example, a woman who is iodine deficient during pregnancy, what impact that will have on the health of the child that you cannot even find out within a few years. You will get to know after many years. So we should promote the use of iodized salt. There are many parts of the country where this is considered a social issue. In northern India, for example, non-iodized salt is part of many religious ceremonies. So people get upset with it. In southern India, Tamil Nadu actually has the highest prevalence of non-iodized salt intake in the entire country. But then that is okay because most of Tamil Nadu is coastal. So if it is a coastal belt, maybe it's not an issue. But if somebody is coming from the interior, maybe from 100, 150 kilometers away from the sea, then we should be promoting the use of iodized salt. So like we said, it's such a big country. You cannot have a single answer for everybody. But as far as iodized salt is considered, I think all of us endocrinologists, physicians, we should all speak the same language. And I get very, I don't get irritated. I just laugh quietly when I see my grocery shelf stocking Himalayan salt, non-iodized, expiry 2021. So the Himalayan salt, the Himalayas have been there for 2 million years. For 2 million years, the salt did not get an expiry date. Now, when it comes into an alternative medication bottle, it is costing 150 rupees a kg. Dr. Petros, normal salt costs 10 rupees a kg. So it's costing 150 rupees a kg and it has an expiry for next year. So this just makes me laugh at the gullibility of my countrymen and women. I think we should all speak together about this. And thanks, Dr. Sridhar, for raising this point.
Thank you once again, sir. As we are running late, I think I would like to thank the Professor Dr. Sanjay Kalra as well as Professor Petros for the wonderful sessions on this thyroid vigilance as well as the subclinical thyroid disorders. Thank you once again. I would like to hand over the program to the organizers. Thank you all.
Thanks for the extraordinary session, sir. We are happy to inform that the delegates' response has been overwhelming and more than 2,500 delegates are logged on live at present. We will continue